Okay, the event is now being recorded. Not seen it live on Facebook yet, but we'll get there.
Right, it's now showing as live on Facebook, gentlemen.
Wonderful. All right, thank you, sir.
Right, no problem. I'll catch up with you at the end.
Wonderful.
Thanks, gents. Enjoy.
Thanks.
Thanks, Alan. Okay, James, good afternoon. How are you, sir?
Good. Glad to see you. And I think listeners ought to know, watchers, you're in Chicago, although you wouldn't guess it from anything from the IT. So, yeah.
No, although I've got a beautiful view, so I'm not quite sure of the building. So I'm on floor 34, and outside my window is a faux Gothic building, which is attached to the top of the Chicago Tribune. So I have no idea what the building is, but it's very pretty. So they say Chicago is the windy city, but it kind of looks like the foggy city at the minute. So
I read somewhere it's the 34th windiest city in the States, despite its name.
All right, Julian.
I don't know how you calculated that or how they calculate that, but having been to Chicago for the liver meetings many times, it was just a sort of thing that amused me.
There you go. So it's only the 34th. So how it got its name, I will never know. I'll never know. Right, I'm going to say hello if you have joined us today. I see a couple of people in the room here in Click Meeting, and I'm hoping we're live on Facebook. Now, the feed hasn't come up on my phone yet. So let's see. Oh, yep, I can see that we're live now. So I'm just going to tune into that. I'm going to turn down the volume, and I will be able to monitor your questions. So if you have any questions today, feel free to pop them in the chat. Now, do please remember that Facebook is a public forum, so anything you write in there will be visible. However, if you do come into the Click Meeting room, anything you write in the chat box here is more confidential. James and I can see it, and we can ask your questions publicly, but it also protects your privacy a little more. However, if you are on Facebook and you do have questions to ask, then please feel free to do that. Okay, it's been a while, so I'm looking forward to this. So thank you very much for joining us today, James. I'm going to ask you the first question, now, which is somewhat topical, because I'm over here for a non-alcoholic fatty liver disease, oblique non-alcoholic steatohepatitis event. Now, we know that this can exist in conjunction with PBC, amongst other liver conditions. So just to put that in there as background before we ask the question. However, the question is, if somebody has PBC, do we know if it's safe or helpful for somebody with PBC to go into intermittent fasting if they want to lose weight?
So if they've got about fasting to lose weight?
Yes. So if they have PBC, would it be problematic in any way to go and use intermittent fasting?
I would be cautious.
Okay.
I think losing weight, and weight is complicated, and on the whole, it's simple in my view. You know, the more you eat, the more likely you are to gain weight. And there's a balance between what goes into your body and what your body uses. And like with a bank account, if you put more in than you take out, you will gain weight, and vice versa.
Yeah.
Losing weight, fasting can, obviously, if you're fasting, you're expending energy, but you're not taking it in, and therefore you will use some of your reserves. But it's complicated because you do get acidotic, you do get ketotic, you start breaking down muscle as well as fat. So fasting, yes, will help lose weight, but for anybody, whether or not they've got PBC or not, I would be very cautious about relying on fasting. There is the 5-2 diet that is quite effective. But I think for most people, the key to losing weight, my own feelings, and this is not for people with PBC specifically, is don't go on a diet. If you do go on a diet, two things will happen. One is you're spending your life focusing on your intake and your diet, and that's not a good thing. Secondly, people who go on these diets, like the ketone diets and so on, they're very good at losing weight. But as soon as you stop the diet, then for many people, you go back to your old eating habits or more so, and all the weight you've lost reaccumulates. So yes, they are effective in helping you losing weight. And for most people with PBC that's not advanced, it is no more risky than if you didn't have PBC. But to my mind, the secret is not to go on a diet, but to change how you eat. And I think there are a few simple guidances to consider. One is don't eat between meals. For many people, you know, a small snack when you're having a coffee. So don't eat between meals. The second advice I would give is don't give up on things you enjoy. We're programmed to have sweets, to enjoy sweets, chocolates, cream cakes, and so on. That's because for most of mankind's existence, there's been a shortage of food, not an abundance. So if you give things up you enjoy, you're going to cheat, you're going to go back. So eat what you like, but eat sensibly and eat less of it. So if you have 4 potatoes, go down to 3. If you're having 2 spoonfuls of custard, have 1. So eat less, don't eat between meals, don't delude yourself. It's amazing how, and again, there's a number of studies that have looked at this. People who are overweight overestimate the amount of exercise they take on the whole and underestimate the amount they eat.
Yep.
And these old things like, you know, if nobody sees you eat, it doesn't count. or the diet cancels out the Mars bars. You know, we're all, and I'm particularly good at self-deception. So we just got to be careful, you know, be honest with yourself. But I think, and another thing I would say is where you can use low-calorie, low-fat alternatives. So if you're getting a bottle of Coke, go for the diet, sugar-free ones. If you're having milk, if you can, go for the semi-skimmed rather than the full-fat milk. Okay. They're all small things.
Okay.
And the final advice, sorry, going on a bit, is what you want to do is to aim for a slow reduction in weight.
Yeah.
Set your targets for 1 or 2 pounds, whatever that is in sort of centimeters, as it were. You know, go for a slow but steady reduction in weight. Don't weigh yourself every day. You know, these old things you can lose weight by cutting your toenails and you know, picking your nose and all that sort of thing. No, but just weigh yourself once or twice a week. Don't eat between meals. Eat smaller portions, but eat what you enjoy. Yes, taking more exercise is always good, and avoid high-calorie things when they're low-calorie alternatives which are acceptable.
Okay.
Just do it gently, and yeah. But I think a fasting diet is quite a radical way. And there are times that you do want to lose weight quickly. But on the whole, do it slowly, gradually, and change how you eat is my recipe.
Okay, perfect. That's helpful. Thank you very much. And we are 10 minutes in, and I'm going to give the first plug of the day. So our Q&A session next week is actually going to be on self-management, or if you're US-based, looking after yourself, looking at your lifestyle choices, and doing that in a way that supports your emotional and mental well-being as well. So if you want to come in for that and ask your questions, and again, we can take some of James's very detailed answers and look at that in more detail if that's appropriate for you. So again, just to offer that to you and make sure that you're aware of that. Okay, thank you very much for that, James. And I appreciate the detail that you've gone into there. The second question we've got today is to do with the combination of earth products called urso or UDCA or ursodiol or ursofolk, but also bezafibrates. So we've got somebody who is on both treatments. So again, maybe you could talk a little about first line and second line therapy. But the question is, now that they have responded and their numbers are good, are there any long-term safety implications from being on urso and beza?
Right, this is
A nice
challenging
easy one
question.
for you.
Thanks. Right. The management of PBC, the treatment of the condition, not the symptoms, is covered by guidelines which have to be tailored to the individual. So for everybody, you know, this doesn't apply to everybody, and you need to talk about it with your doctor or nurse to get the right treatment for you. The first line treatment is urso, and the key thing is the foundation, and Robert has plugged endlessly, but still need to continue to get the message across, is make sure that you have the appropriate dose. If you can tolerate that and your liver tests return to normal, great. That's all you need to do.
Yeah.
If they don't, or you don't tolerate the drug, the urso, then you go on to second line treatment. Licensed second line treatment is obeticholic acid, OCA, and that is licensed in most countries. And there's no doubt that people who don't respond fully to urso, a significant proportion will respond to addition of obeticholic acid, and that's all you need to do. Now, obeticholic acid has its problems. Not everybody can take it for a variety of reasons. And there's a lot of interest in this drug called bezafibrate. Now, bezafibrate is a different type of drug. It's been used for many years for the treatment of lipid disorders in particular. And it's important to say that it's not licensed specifically in most countries, as far as I'm aware, for use in PBC. That having been said, there's a lot of experience for its use in PBC, and there's good evidence that for some people, many people, it is an effective treatment. But what you need to do is, if the urso doesn't work, some people will benefit from going straight to beza or other fibrates. Others might be advised to take obeticholic acid. It depends on the symptomatology, amongst other things. Now, in general, all drugs must be considered as having risk. And for any treatment, you have to balance the risks and the benefits. And when I talk about drugs, I don't just mean drugs prescribed by the doctor or nurse or pharmacist. It's drugs over the counter, it's herbal remedies, it's vitamins. All these additives that you stuff into your body have sometimes benefits and sometimes risks. And for any treatment, you have to balance the risks and the benefits. And certainly beza in the short term, like it can cause a number of side effects. And some of these you may pick up with blood tests, others you may pick up with symptoms. But for those who, and bezafibrate is not without its side effects. So in general, you have to balance the benefits and the risks. Most people tolerate them fine, but you do have to monitor people, make sure that the benefits are still persisting and the side effects are not a problem.
Yeah.
And therefore, for most people, long-term urso and beza is a safe and effective combination. But you do need to remain on the alert, and to say it's free of risk is naive. But that's true whether you're taking vitamin tablets, henbane or anything else, any other natural remedies. They also have side effects. So just be careful. And you're absolutely right to question the long-term use of any medication. But we know, for example, from ERSO, which is the best studied in PBC, that on the whole, it's extremely safe. But always question, why am I taking medication? Do I need to take it? And if you've got PBC and you respond to ERSO, for most patients, there's a very clear yes.
Yeah, no, that's
But do keep challenging your doctors and nurses.
perfect. No, that's helpful. Thank you. I'm going to come back to you with a second question, if I may. Now I'm in Chicago, so I've been watching UK activity today from afar. But we're going to allow secondary questions or follow-up questions, if I may. So you hit a really, really important point in terms of, everything that we take into our system has a side effect. Now, one of my drums that I've been banging is personalized medicine. Is actually looking at the patient as a whole and picking the best way forward for them. And so I'm kind of loading the question for you, James, but I guess, we hear when we talk about bezafibrates that there are risks of kidney toxicity, there's risk of liver toxicity. When we talk about colic acid, we talk about the potential of itch and all of those kind of things. And I guess what I'm highlighting is, yes, there are risks there, but for different reasons, these drugs can still have a positive impact on patients.
Yeah, I mean, you put it very well. Yes, side effects. Yes, benefits. What's the balance of risk? And I mean, to take a more extreme example of more, if you like, more obviously toxic drugs, some of the chemotherapy drugs that people take have severe side effects on bone marrow, maybe life-threatening. But, if you've got a 1% chance of getting a severe infection and a 70% chance of being cured of your cancer, it's a no-brainer. But the key thing is for the person who's taking the medication to be aware of the risks, and they're the ones who should make a decision, because they're going to bear the consequences both of the benefits and the side effects. So personalized medicine is absolutely right.
Yeah.
It needs to be tailored for you with the doctors you're talking to. Do be aware of side effects. Leaflets, packets of medication come with a patient information leaflet, we call it in the UK, PIL, and do read it. They do rather overstress, or they do quite rightly emphasize the side effects, but do read it. And if you have questions, talk to your doctor or nurse and ask them to explain, put it in context for you.
Okay, perfect. That's helpful. Okay, thank you. So again, one of the things you talked about was also dosing. So we've moved from a drum that I've been banging for a long time now to a full-on orchestral because I think this needs to be banged loud and hard and often. So we've had a question from somebody who's on 500 milligrams of Urso a day. So I'm sure you're going to comment on that. And their ALK-40 is written to 215, their albumin is now 33. So again, I am aware and know and fully respect that you can't talk about individual cases, but can you maybe address this patient's circumstances and what we could maybe do to help?
Yeah, I think there are two things really. The dose of Urso, again, read the bare facts, listen to Robert. The standard dose is 13 to 15 milligrams per kilogram per day. There are some valid reasons why people are not on that regimen, but do go and ask your doctor. And again, I don't know the person's weight, so I don't know if they're on the appropriate dose or not. And I can't, in my head, divide 15 into 500. but it's too early in the morning for Chicago, I guess. And it'll give you the answer in kilogram anyway. Somewhere I've got my calculator, but my PBC calculator. But if you're not on 13 to 15 milligrams per kilogram per day, discuss it with your doctor and ask why not. Now, so that's the first thing. Ask them and discuss it with them. The second issue is the alkaline phosphatase fell and it's now rising. Why is that? And there are many potential explanations. Alkaline phosphatase is an enzyme that is produced by the liver, but not only by the liver. And there are bone, gut, placenta, for example, also can produce alkaline phosphatase. So if it's from the liver, which is probable, but not necessarily the case, then why has it gone up? Is that rise just a one-off? Is it a consistent rise? And if it is rising, having fallen, then again, talk to your doctor and ask him or her for an explanation. It could be related to the fact you're not on enough urso. It could be related to other factors within the liver. You could have, for example, a fatty liver. You could have diabetes. You could be taking other medication. You could have bile duct problems. So there are all sorts of reasons why the alkaline phosphatase might be rising. As I say, it could be due to you're not getting enough urso. So if you get a one-off change, then if there's no change in your clinical situation, my normal practice would be to repeat it and see if it's just a blip. If it goes back to normal, then I wouldn't worry. If it's a sustained rise, then depending on the situation, I'd investigate further.
Yeah.
So I wouldn't leave it in limbo. Talk to your nurse, talk to your doctor and say, you are concerned. Can they either reassure you or do you think it needs further investigation? And depending on what the cause is, additional treatment may be indicated or not.
Okay.
Yeah.
Perfect. That's helpful. All right. Thank you very much. Okay. My next question is to do with osteoporosis. So again, which you may want to define or give a little background to. But somebody with osteoporosis has had a couple of broken bones in their foot. And whilst they've been walking on those, they've also had ulcers on their feet. And the question is, do you think that this could be related to PBC?
Possibly yes is the answer.
Okay.
Osteoporosis means thinning of the bones. There's less calcium there. There's less. They become less. They become essentially thinner than they should be. Now, as you get older, you do tend to get more thinning of osteoporosis is more common. And there are many factors that will predispose people to osteoporosis. Genetic factors is one. There's some familial types of osteoporosis, and if your parents had osteoporosis, you're more at greater risk.
Okay.
If you're female, you're also at greater risk of osteoporosis, particularly postmenopausal. If you smoke, you're at greater risk of osteoporosis. If you take certain medications, you're at greater risk of osteoporosis. Some evidence that alcohol predisposes to osteoporosis.
Okay.
If you don't take enough weight-bearing exercise, you're predisposing to osteoporosis. So we're finding, for example, that people who've gone into space where there's zero gravity for any length of time, I'm not talking about Elon Musk and Richard Branson, but the astronauts, they lose a considerable amount of bone by the time they come back to Earth.
Okay.
But also is chronic liver disease, and particularly cholestatic liver disease. So PBC is another predisposing factor for osteoporosis. Why does it matter? Well, it leads to bone fractures, and the ones we worry about more are spinal, the vertebrae collapse, and that's very painful. The old dowager hump, the sort of rounded osteoporosis can give it to you. And more sinister, particularly as you get older, is a fractured neck of femur, which can be very serious.
Yeah.
And so, yes, it's if you have osteoporosis of the bones and you fractured that, the PBC may be a contributory factor. What can you do about it? Again, talk to your GP. They might want to do what we call a DEXA scan, which measures the density of the bones, usually in the spinal column, or on the vertebrae and the hip. And you get two scores. One is a Z score, the other is a T score, I think. One tells you the bone density relative to the general population. The other is relative to your age.
Yeah.
And it will also work out a risk of hip fracture. If you've got no osteoporosis, then often no extra treatment is indicated. But if you've had a fractured bone, then probably it is. There are first-line treatments such as calcium and vitamin D, and there are other treatments that will be helpful in retarding bone loss. So talk to your doctor. So if you've broken a bone in your foot, then you've probably got significant osteoporosis. Talk to your doctor about further investigation and management, whether there's medication that will help. But the key thing is keep exercising, weight-bearing exercise, so walking, running, swimming doesn't help your bones. It's good for you in other ways, but it's not weight-bearing.
Yeah.
And don't smoke. But talk to your doctors, see what investigations are required, and see what treatments can help prevent further bone loss.
Wonderful. Thank you. No, I appreciate that. And I'm glad you went again into more detail, because I was going to ask you about weight-bearing exercise and what would count as that. So thank you very much. Quick question, if I may. We've got somebody who is an URSO responder, and they've thrown initials at me that I don't know for once, which is always good. So I've been told that their MPV is 7.8. So first question is, what is MPV? And then my second question is, would somebody with an MPV of 7.8 be concerned?
I wasn't sure what the MPV was. I have an idea, maybe the MCV.
Okay.
Which, in which case, okay, so when they do a blood test, they will often do the full blood count, which includes the hemoglobin. And the machines will also look at the red cell size and shape, because that can tell you a little bit about particularly vitamin D, sort of iron deficiency, or folate or B12 deficiency.
Yeah.
Now, if the MCV, which stands for the mean corpuscular volume, if that is what the person is saying is falling, then the question is it falling back to normal? Because if you're B12 deficient, your MCV is increased. So if it's falling back to normal range, that's a good thing. If it's falling below the normal range, then that could be due to many factors, including iron deficiency. And it should lead, again, talk to your doctor or nurse, find out more what it means for you. And I can't say should you be worried, but if things are changing, it's always important to understand why, because there may be reasons for it that either need further investigation or further treatment. So if you're iron deficient, that's why the MCV is falling. The question is, right, you can give iron that'll help that, but the question is, why are you iron deficient? But without knowing more, whether it is the MPV, I'm not sure. I will double check, but I think it may be the MCV she's referring to. And if I'm wrong, forgive me.
James, as you know, internally, we refer to Alan as the font of all knowledge. And I've just had a message from Alan saying that MPV stands for mean platelet volume.
Oh, right. Oh, if it's the platelets, we don't normally measure that. I'm not sure if it is the platelet volume is lower. If it's the platelet count is lower, then again, that may be due to one of many factors, including an enlarging spleen.
Yeah.
But that would be the platelet numbers. I don't know enough to say whether if the mean platelet volume is not a parameter I normally look at.
Yeah.
And again, I would talk to your doctor, who will certainly know more than me on that.
Okay. Perfect.
Sorry. Yeah.
Okay. No, that's helpful. Alan, thank you for chiming in there. That's helpful.
Thanks for that. Yeah.
It's nice to be back, and it's nice to. It's funny, you know, I talk about the foundation and how dear it is to my heart, but just moments like that where it just reminds you of the way the team works and how we do what we do and why we do what we do. It's a really nice thing. So, Alan, thank you. I appreciate that. Right. Next question is insect repellent. With PBC, can you, should you, can you not? What's your thoughts?
I'm not aware that the normal, I mean, there are some pesticides that will damage, that can cause damage if inhaled by humans. Hopefully they'll cause damage to the insects as well. As far as I'm aware, and again, this is really outside my competence knowledge, is that normal insecticides that developed for use on the body to keep away insects are safe. I'm not aware of any evidence that they're harmful in those with PBC or other liver disease, but always avoid inhaling them and use them as directed. But I'm not aware that there's any additional problem. I may be wrong. It wouldn't be the first time. It certainly won't be the last. But I'm not aware of any issue.
Okay, perfect. Thank you very much. Another one which I think we could probably cover quite quickly. What does it mean if your numbers have improved to the point that they're good, but you've become AMA negative?
It doesn't mean a great deal, to be honest. It is one of the, it has been recognized for many years on it that people taking URSO often do become negative, or the tests for AMA become undetectable. As far as I know, there is no implication in that, either good or bad.
Yeah.
But it's been a recognized phenomenon that it does fall. I'm not aware that it has any significant implication for you or something to be worried about or indeed pleased about.
Okay.
It's unlikely to be a bad thing, but that's my understanding.
Okay, perfect. Thank you. So it shouldn't be seen as a cure and a reason to come off your URSO then?
Absolutely not.
Okay, perfect. So,
always, as you were hinting at.
So, absolutely. Okay, perfect. Thank you. Here's a question for you. So this takes me back to right at the start, back in March 2020. Does COVID affect the liver?
Yes.
Okay. Would you give me any more detail on that, or are you just leave it?
No, it does, and certainly it can affect the liver. You can get a hepatitis. It can lead to an autoimmune reaction.
Yeah.
And so, yes, it can. Whether people with PBC are more susceptible to liver damage than others, I'm not sure there's a lot of evidence either way.
Okay.
But anybody with any form of liver damage can have rises in liver tests, but we know that with cold and flu, again, you can get abnormalities. So yes, it can affect the liver. It rarely causes additional problems, but obviously if you've got particularly advanced PBC, the impact of COVID will be more serious usually than if you've got well-controlled or early PBC. But yes, it can.
Okay. Thank you. Right, so a question here. So I'm going to go into a little more detail because I have multiple questions, not all of which you can answer, but they're just, again, questions. So I'll give you the background, then I'll give you the questions in my head, and then we'll give you the question that we can maybe ask you to answer. So we've got somebody who lives in Redditch, and for that, I can only apologize. It's a part of the world I know very well. So anyway, so we have somebody who's in Redditch. So for those of you that don't know, Redditch is in the West Midlands of England. So first off, they are at a hospital, which is about a 45-minute drive away from Redditch. They're required to attend every month for blood tests for their PBC, which is one of my questions in terms of, where would somebody be that they would need to go every month? And, is that the best thing for their care? But because of the time involved, because of, the fatigue of going in and out every month, time taken off work, all of those kind of things, they're asking, is there a hospital in or around Redditch they could go to? Or is there anything else that they could do that we can advise to help them with their care?
Right. I think the first thing that, as you alluded to, Robert, is how frequently do you need blood tests?
Yeah.
And that depends on the clinical situation, what medications you're taking. There's some drugs like azathioprine, other drugs where you probably need, certainly in the early terms of their use. Rifampicin, another drug where there is potential for hepatotoxicity, and your doctor may feel that they need to monitor your liver closely in order to make sure you're not getting adverse side effects. The well-compensated PBC with early disease, who's responding well to urso and is asymptomatic, again, one usually needs far less frequent blood tests. Yeah. So I think to find out from your doctors why they recommend monthly ones, and there's some very good reasons and there's some less valid reasons.
Yeah.
The second thing is, how do you have your blood taken? Well, we used to live in Elfchurch, which is it's actually a village technically, but it's larger than the town where I live in now, stuck between Bark Green, which is the upmarket part of Birmingham, if there can be said to be such a thing, and Redditch, which is in Worcestershire. There is a hospital. So the options you should explore is, where can you have your blood taken? One is, can they be done at the GP surgery?
Yeah.
And there are quite a few in Redditch. Can it be done at the local hospital, say at the Alex, which I think still is open. I don't know whether they have a venesection.
Okay.
There's also obviously Worcester, which is quite a drive away.
Yeah.
And going further into Birmingham, you've got the QE. The problem with the QE, it's in a different health authority, as far as I recall, and there may be difficulties in getting results from the QE, say, to who's ever looking after you.
Yeah.
So talk to your doctor. Say, one is, why do I, understand why they're recommending it to be done monthly. And as I say, there may be very valid reasons. Can it safely be reduced in frequency? Again, ask for that. Then I would say, where could this be done? Could it be done at the general practice? Are there other venesection hubs? There used to be. I know the QE had various hubs around town, like at the train station, where you can have bloods taken. So see if it can be done nearer home. or nearer work, less inconvenient. But if your doctor says it's important to have these tests done on a monthly basis and for the following reasons, then it's important that it is done and you find a way that's least inconvenient to you, but also making sure that whoever requested the blood test gets the results, and if they are abnormal, can act on them.
Yeah.
Because having the blood taken is just the start of the process.
Yeah.
The person who requested them has got to get the results, look at them, and act if appropriate.
Yeah. No, I get that.
Otherwise, yeah.
Okay. So I'm going to err into the realms of the hypothetical world, and I'm going to muse aloud and see what your thoughts are. As you said in your answer, there may be absolutely valid reasons to take blood tests every month. And I'm thinking of the ODN network in England. So this kind of hub and spoke network. So for example, in England, if you are a non-responder, either to URSO or to first-line therapies, for example, for itch, then the guidelines and the protocol would be that you're then referred to an ODN, which is an operational delivery network. So this is an area of expertise. And for example, they have the license to prescribe obeticholic acid in England and Wales. So if, for example, you were on a second-line therapy or a second-line therapy for itch, which again would need to be monitored, then perhaps the best thing to be would to make sure that you're actually at one of the ODNs instead of a local hospital. You know where I'm going with this? Thoughts?
A lot depends on who it is looking after you rather than where you're being looked after.
Okay. If
you're being looked after and whether you're the clinician in charge of your advising about your liver disease, about your PBC as a GP, specialist nurse, hospital doctor, gastroenterologist or hepatologist, is less important than are they doing it properly. That's the key thing. And we do, for example, in Birmingham, have close liaisons with several hospitals where we work to a common purpose and a common protocol. And the key thing, and again, just talking about the liver disease, not the symptoms, which is another huge area and a really important one, is URSO. So what is the diagnosis? Are you getting URSO? Are you tolerating it at the right dose? Is it having an effect? If it is, then you just get monitored for symptoms and so on, and side effects. If you're not responding, that's really where you need to make sure that your clinician is up to date, and whether they are talking to a specialist who knows and can say, well, I would recommend OCA, I would recommend bezafibrate, or one of the other medications. That needs to be, and going back to what Robert said about personalized medicine, to get what they think they would advise is in your best interest. If the way they ensure that the use of obeticholic acid is appropriately prescribed is it goes essentially to a multidisciplinary team meeting just to make sure that it's appropriate and safe for that person. So as long as there is discussion and presentation, you will get the best treatment. But if it's not, just because it's in the specialist unit, like for example the one I work in, you may see somebody who's a junior doctor who's not up to date, perhaps. So it's getting the right treatment. Who gives it is less important, and there are protocols in place. And if you're in a non-specialist hospital, I wouldn't worry, provided your doctor is in touch with the specialist who can make sure you have the right treatment and your results. So, people want to be treated locally with the least inconvenience. And as long as your doctor is collaborative, we are getting better at working in networks. That's the key thing. So that's what you want to find out.
Yeah.
And you want to go for the minimum, safest, effective treatment.
Perfect. Okay. Again, that's helpful. Thank you. Okay, we've had a question with regard to dry, itchy eyes. So we can talk about dry, itchy eyes. It might also be helpful to talk about dry eyes. And then it might also be helpful to talk about itchy eyes, because I know, for example, when we've heard some patient testimonies and people talking about their personal experience, we've heard people who have PBC itch, also known as pruritus, to talk about, for example, itch behind the eyelids and all of those kind of things. So again, I just want to differentiate between dry, itchy eyes, and itchy eyes. But taking all of that on board, James, what can you tell us?
Again, many causes of dry or itchy eyes, and dry eyes may lead to itchy eyes and vice versa, but not the other way around.
Yeah.
So one needs to declare what one means. In people who are prone to get PBC, you may also get dry eye syndrome, whereby the tear ducts become damaged in this comparable way to the bile ducts.
Yeah.
And they produce fewer tears, which lubricate the eyes. That leads to drying of the corneas and can lead to scarring and damage.
Yeah.
Other factors, for example, viral infections, even bacterial infections, can cause dry, itchy eyes. So if it's long-term, it's unlikely to be that. But the key thing is, if you have symptoms in your eyes, go and see somebody who knows what they're doing, who can look at your eyes, make a diagnosis, and give you appropriate treatment. Most chances are, if you have PBC, that it's dry eyes as part of the so-called Sika syndrome or Raynaud syndrome. Sorry, not Raynaud. It's a part of Sika syndrome, or but get it checked out, get a clear diagnosis, and if it is Sika syndrome, then again you need to consider artificial tears. There are various forms of that. You can even get human tears, and have regular eye checks to make sure that the eyes are not being damaged. But the key thing is go and see an expert. It could be a GP who may refer you. It could be the local optician.
Yeah.
The good ones are very, very good and safe, but don't ignore it. And it could be it's not caused by the PBC, but people who have PBC are more likely to get Sika syndrome, and indeed people with Sika syndrome are more likely than the normal population to have PBC.
Yeah, I understand. Okay. Thank you. Okay. Next question we have, CBD oil and CBD drugs.
Yes, this is, I saw that one and my heart sank. We did write an article in the Bare Facts. Do you remember, Robert, 2 or 3 years ago?
Yeah.
Where I did research that. They're different. The general advice is be very cautious with the cannabis oils. They can cause liver damage. The evidence in PBC is not very strong.
Yeah.
But I think the evidence is to be very cautious about their use. And it goes back to thinking of what are the benefits, what are the risks. And I'm not sure about the benefits. It may help well-being and so on, and that's important. but it may damage the liver, and it wouldn't necessarily show up in abnormal liver tests. It might just mean the rate of scarring is more accelerated. So I'd be very cautious about it. And my advice is, unless it's really important to take it, in general, I think people are better not taking unnecessary chemicals into their body, and that applies not just for cannabis, but for any other chemicals.
Okay, perfect. That's helpful. Okay, thank you very much. We've had a follow-up, if I may, in terms of going back to dry HAI. So somebody's saying that they've been diagnosed with Sjogren's and they have issues with overall dryness, and that's including the eyes.
Yeah. Again, so the dry eyes is particularly one that people notice. Dry mouth, again, where it's the salivary glands that get affected and bear the brunt. And again, there is no cure for that. The treatment is artificial saliva. I suspect human saliva could be used, but it's probably not aesthetically tasteful. And again, perhaps I should have said that there are a number of different preparations, both for artificial tears and artificial saliva. And go to your GP, ask what they would recommend. If it works, great. If it doesn't, or you can't tolerate it, ask for a different preparation. So both for the eye, the other place where obviously women get it, it's vaginal dryness, and for obvious reasons, people are often reluctant to raise this with the doctor. But again, using appropriate lubricants and sometimes hormonal creams, depending on the person's situation. So that's all part of the Sjogren's. So I think there's some confusion as to whether Sjogren's is just the eye and Sicca syndrome is all three. But basically it's this secretory glands. Some people think the pancreas may also be involved in a similar way. So don't suffer in silence. Tell your doctor and tell your optician or tell your dentist, and they can check there's nothing else going on, and they can discuss treatments with you. But they're not cures, they're treatments. It's not. Also be aware that particularly dry mouth, some drugs, some medications can cause that. So again, when you raise it with your doctors or nurse, bring a list of your other medications, because that can exacerbate the dry mouth, and just bear that in mind.
Absolutely. Okay, that's helpful. Thank you. Okay, we've had another question, which again gives me the opportunity to roll out the drums, the timpani, and the cymbals. And again, this goes back to partly to do with ESO, where we were a couple of weeks ago, partly to do with the UK PBC audit, partly to do with the app data and the surveys that we've done as an organization. So it's not our place as a foundation to recommend trials or to push people into trials. However, what we are witnessing through the entire piece is that not enough patients are given the opportunity or even given the information in terms of their ability to participate in clinical trials. So, I mean, I think the last app data was maybe 4% of non-responders were given an opportunity to be involved in clinical trials. So given that there are so many trials around, and not just in disease management, but also in symptom management, what can we do to empower patients in terms of their involvement, and what can we do to support the clinical community in terms of making sure that they're as informed, as involved as they want or need to be?
Right. I mean, I would totally agree with what you said, that we strongly encourage people to consider taking part in trials and to do so if it's right for them.
Yeah.
The only way we can progress our understanding and treatment, more of PBC is by people participating in trials. To run a trial in the NHS requires an enormous amount of bureaucracy, and the amount of in the early days of 30, 40 years ago, people did trials. They did them badly and sometimes unethically. People were not given due consent. They were not regulated. And going back 50, 60 years, certainly some really appalling trials were done on Down's children for hepatitis B, for example. So quite rightly, some regulation and oversight was brought in. But along with that, like so many things in life, and it's not down to the EU, although they've contributed, there is a significant bureaucracy.
Yeah.
And as somebody who's done trials and continues to support them, it's an awful lot of extra work. And the PBC is going to be sponsoring a first for the foundation, and you'll hear more about this later. And there's a huge amount of paperwork that has to be done. The doctor has to undergo training, good clinical practice. The hospital has to approve. There's a huge, 45-page ethics form that has to be completed, and so on. And there has to be monitoring to make sure that data from the trial is accurate, and there have been too many cases of doctors and others falsifying data, and so on. So the regulation has come in part due to malpractice and poor practice and dishonest practice. And during COVID, particularly, most clinical trials were stopped on safety grounds. Another point I'd make is that some trials are very are targeted at specific, not just people with PBC, but people with particular part of PBC, with, say, early disease or late disease, people who've not had URSO, people who've had URSO and not responded, people who've had URSO and couldn't tolerate. So they have very well-defined groups, and not everybody, therefore, would be suitable for each trial.
Yeah.
That having been said, not all hospitals do have this, either the time, the resource, or the willingness to participate in trials. And what we can do as the foundation, I think we have been doing, but clearly need to double our efforts with the new CEO, is to make people aware of what trials there are.
Yeah.
What are the entry criteria? What does this involve for the patient who participates? What are the risks? What are the benefits? What happens if things go wrong? So to give you the information, as I say, whether you take part in the study is entirely up to you. You do have the right to withdraw at any time without explanation.
Yeah.
If you decide not to take part, or you do decide to withdraw, that is not allowed to adversely affect your care. They can't take it out on you. And so I think we can redouble our efforts to let people know about the trials.
Yeah.
And if your hospital isn't doing it, then where's the nearest hospital that does? And one of the issues is that trials do involve often additional blood tests, additional hospital visits. And if you're working or have to travel, then that may not be possible to do. So we can do more to let people know and encourage them, if they want to do trials. If your hospital isn't a registered trial site for that trial, then can you be referred to another hospital that will do it? Because if your hospital is not signed up for the trial, it hasn't given approval, it hasn't been included in the approval process, then they cannot enter you into the trial, but you can get referred to another hospital that might take you on.
Perfect. Okay.
Yeah.
Ideal. All right, thanks, James. I'm aware of time. Do you have time just for a couple of really quick question answers? James, are you still there?
Yeah, still there. Yes.
Okay. I say I'm aware of time. I know that we're close to the
Yeah,
hour.
No, I've got a few more minutes. Yeah.
Okay, perfect. So very, very quickly, insomnia and PBC, are they related in any way?
I think they probably are. I think they probably are is the answer.
Yeah.
I don't know, and you'll probably know more, Robert, of the studies that have been done on this, but I think probably that they are related. To what extent they are, I'm not sure what the causes are. Again, so I don't. You'll probably know more than I do on this.
Okay, no, thank you. So very quickly, and again, plugging our self-management session next Thursday, 2 p.m. UK time. So we know that insomnia can be a feature, and particularly if you suffer from a severe symptom burden. So, for example, if you have itch and if the itch affects you through the night, or the itch can wake you and then you can't fall back asleep. If you have fatigue, and then you sleep through the day and then you're not able to sleep at night, but because you've had a sleep instead of doing something more proactive, then actually you're not addressing the fatigue either. So there are a number of issues that can be helped with a more proactive self-management approach that may or may not be linked directly to the mechanisms of PBC, but certainly to the burden of living with it, if that makes any sense. So thank you for that question. And the last question I have for you, James, if I may. So we have somebody who has been diagnosed with ulcerative colitis. They're currently being treated with steroids, biologicals, and immune suppression. The concern is, will those have an impact on their liver and or their PBC?
Possibly, yes, possibly in a good way. So again, you have to balance. So with ulcerative colitis, treatment has been revolutionized by a modern approach to therapy, appropriate use of steroids, appropriate use of things like infliximab, and some of the newer drugs.
Yeah.
And I remember as a student the days of people having colons removed for bad colitis, people dying of colitis. So yes, treatment has changed enormously and for the better. Some of the drugs may affect the liver, but the important thing is to treat the colitis effectively, because bad colitis will also damage the liver as well as your life, lead to colons removal and so forth. So while these things are being taken, depending on the drugs, depending on the agents, to monitor the liver tests and keep an eye that they're not adversely being affected. But there are some drugs that people need for other conditions that can damage the liver, but you've just got to weigh up. So, for example, methotrexate, which is one of the agents that can be used, that can damage the liver. And there are often alternatives that can be used for people with PBC. So it goes back to this concept of personalized medicine. What you want to do is to get the greatest treatment effect for the minimal risk and side effect.
Yeah.
And collateral damage to the liver may be a risk you take, and therefore your doctors have to work in collaboration if it's outside their specialty. But to get it the right package for you, bearing in mind the colitis and the PBC, it's no good having, dying of colitis with a perfect liver, and equally it's no good having a perfect liver if it damages a perfect colon if it damages your liver. You want a great colon and a great liver.
Absolutely. So, and again, thank you, James, and again highlighting the need and the benefits of personalized medicine and personalized care. So thank you so much for today, for your knowledge and wisdom. Alan is back. That means he's going to kick us off now. So for those of you on Facebook, thank you very much for joining us today. I hope that's been informative. Do bear in mind, we have our next clinician Q&A session in 2 weeks' time. Meantime, next week, Thursday, 2 p.m. UK time, we will be looking at self-management. And as well as that, we have our usual chit-chats on a Monday and Wednesday. Friday the 15th, we have our first Friday Fizz, under which circumstances anything could happen. So I'm just going to apologise now. And other than that, I shall leave you to the rest of your day. So James, thank you very much. Alan, thank you very much for joining us today. Thank you.
Thanks, gentlemen.
All right. All the
Thank
best.
you.
Bye. All right,
Okay,
Alan.
Robert. Sorry?
Thank you, sir. I appreciate that.
Oh, bear me a second, right. I'll just close everything down, okay?
All right. Thanks, mate. Take care.
Cheers. Bye just now.